Kiranjit, you can start. Make it live.
A very good evening to all. I am Dr. Kiranjit Kaur. I'm working as a project coordinator in the Department of Community Medicine and School of Public Health, PGI, Chandigarh, and I will be the host for today's symposium. It gives me an immense pleasure in welcoming you all to the National Symposium on COVID-19 vaccination among children and adolescents in India. So before we start the sessions, I would like to request and invite Dr. Madhu Gupta, the professor from Department of Community Medicine and School of Public Health, PGI, Chandigarh, the organizer of the symposium, to deliver a welcome address and also share with us the objectives of today's symposium.
Thank you, Dr. Kiranjit. A very good evening to all the eminent resource persons, panelists, honored guests, faculty, resident doctors, and medical and all who have participated in this symposium. It is indeed an opportune and fortunate moment for us that we have all gathered here on this National Symposium platform with an aim to discuss the need for COVID-19 vaccination among children and adolescents in India. Vaccination is a proven and most effective, cost-effective child survival intervention. So as you are aware that COVID-19 pandemic has already severely disrupted access to health services worldwide. Keeping in mind the evolving situation of COVID-19 pandemic and the emerging evidence, the Ministry of Health and Family Welfare has decided to expand the COVID-19 vaccination program to children aged 15 to 18 years from January this year, and 12 to 14 years since March 2022. And recently, DCGI has given nod to the administration of COVID-19 vaccine to children between 6 to 12 years of age. Schools had made COVID-19 vaccination mandatory, or they were given the instruction that they had to stay at home, but with the court order, and this was taken off. So sometimes we feel that even the opinion of healthcare service providers is also divided regarding COVID-19 vaccination. So hence we thought there is a need to discuss at length about this issue at the national level. So I'm very happy and grateful to the resource persons and the panelists. So I welcome Professor Gagandeep Kang, a prominent face in the field of microbiology and vaccinology, Dr. Narinder K. Arora, who's the Executive Director at Implant Trust International, New Delhi, and he's also a chair of National Technical Advisory Committee, and we'll be hearing from them. Dr. Naveen Thakur, who's the President-elect and International of the International Pediatric Association, for being moderating the panel discussion. Dr. Vipin Vashishta to be he's a renowned pediatrician to be part of the panel discussion. Dr. Chandrakant Leheria, we have been reading about his various articles. He's a renowned epidemiologist and a public health specialist. Ms. Anjali Nair, who is an executive president, Global Health Strategies, New Delhi, for sparing their time in the panel discussion. I also welcome our chairperson, Professor Sameer Malhotra, who's the head of the Department of Pharmacology at PGIMER, Chandigarh, and for chairing the sessions, first session, and Professor Sunila Garg, who at the last moment, I'm really grateful, ma'am, agreed to be the chairperson. She's a chairperson of the Program Advisory Committee at National Institute of Health and Family Welfare. And our very, very talented and experts, the resource faculty, Professor Arun Bansal in Pediatric Medicine at Advanced Pediatric Center, Dr. Ashish Kakkar, who's Associate Professor in the Pharmacology Department in PGI, Dr. Tiwari, who's a pediatrician in AIIMS Patna, Dr. Abhishek Raut, he's a professor in MGIMS Varda, Dr. Anil Lakhar from Serum Institute of India. I welcome you all for sparing your time and sharing your knowledge with us in this platform. And I sincerely hope that this symposium meets your expectations. Thank you. So, coming to the objectives. So, basically, the objective are to discuss the need of COVID-19 vaccination among children and adolescents in India, and provide related policy recommendations. Thank you.
Thank you, ma'am. Now, ma'am, I would kindly request you to please introduce the chair for today's session.
I think the first chair is Dr. Sameer Agarwal.
Yes, ma'am. Dr. Sameer Malhotra.
I would also like to extend warm welcome from our director, Dr. Vivek Lal. He had agreed to welcome you all, but there was a last minute meeting which has come up and he could not come. So I welcome Professor Sameer Malhotra. He's heading the Department of Pharmacology at PGI. Sir has a experience of more than 20 years in PGI. He's the chairman of Institute Ethics Committee Intramural and also former convener of the Ethics Committee in PGI. He's the chairperson of IEC at Nabi Mohali, Punjab, and chairperson of Meeting of Research Advisory Committee, Government Medical College, Amritsar. Sir has a membership in various scientific societies. He's executive member, World Non-Communicable Disease Federation, member Indian Pharmacological Society since 1997, member Indian Society of Physiology and Pharmacology since 2003, and member International Society for Heart Research, Indian section. So thank you so much, sir. Over to you, sir.
Thanks, Dr. Madhu. Am I audible?
Yes, sir, you're audible.
Okay. Very warm welcome to all the participants. I can see a very large number. It's crossing 100. Congratulations on that. So, first I would like to invite Dr. Arun Bansal, professor in pediatrics in PGI Chandigarh. He's a pediatric intensive care expert and also has worked on infectious disorders. So he's the most appropriate person to talk about COVID-19 vaccines among children and adolescents. Dr. Arun, please.
Thank you. Thank you so much, sir. Good evening, everybody. To all the seniors, colleagues from public health, vaccinology, and pediatrics. Thank you, Dr. Madhu, for giving an opportunity to speak on this August platform. We already see that the house is full. So what I'll be speaking is on this epidemiology and management of COVID and MISC in children. So maybe I'm the opening batsman, and to set the ball rolling on the vaccines and the need for vaccine, this is very important to know that how much is the burden of COVID and what is the severity and how do we do the basic management of these two problems which we have been seeing since last 2 years. Okay, so what I'll be speaking on is the basic epidemiology, classify the COVID-19 into various severity classification and its management, and then how to recognize MISC and its management in brief. So if we have to see that what is the burden of COVID-19 in the world, we've seen that mainly it's a disease of the adults, but it does not mean that it is not seen in pediatric patients also. We have seen lots of pediatric patients coming to us. Globally, if we have to see, this is one of a large study from US, which included around worldwide centers of 51 centers from all over the world, had studied 874 children with COVID-19. And this was done over a period of 1 year. And they have seen that out of these 874, 404 children were admitted, means of almost half. And they were admitted in the ICU. So that means they were quite severe or they needed some kind of organ support for which they needed an ICU care. And out of that, the hospital mortality was approximately 2%. So it's not so uncommon to see deaths with COVID in severe cases of COVID. If we see what is the data from India, this is the ICMR old data when the COVID has just started, when we had seen a lot of COVID cases coming up. In fact, pediatric cases also led up to approximately 5 to 7% of the cases were the pediatric cases. But what was the severity and critical illnesses was not sure that how many of them were severe or were non-severe. This is the PGI data from our own institute, which as of today, we had approximately seen 9,400 cases, out of which 766 were pediatric cases. And there might be more because sometimes we take pediatrics up to 18-year also. So they are around maybe 1,500 odd cases or something. So it corresponds to the world figure that it's approximately 10 to 15% of the cases of the world are the pediatric cases amongst the total adult population. This is what we have seen in APC, and we have published our data in Indian Journal of Pediatrics last year. This data was of the second wave, of the first wave. In April 2020 to 15 July 20, we saw 31 children of COVID, out of which almost half are asymptomatic. And very few children, that is only 10% required PICU admission and invasive ventilation, but we also saw one death. But mind it that that was the period when the COVID was not very, the load was not much at that stage. And only during the second wave in April 2021, we saw a lot of cases coming up in that stage. This is another data which we have published on MISC in Journal of Tropical Pediatrics of 40 cases. We now till date have seen approximately 100 cases of MISC, but this 40 cases data has been published, which required almost all required ICU admission. Almost some kind of support was required, like oxygen, ventilation, invasive or non-invasive. Majority, almost 80%, had shock, requiring some kind of inotrope or fluid polysis. And they also required IVIG and steroids and other kind of management. So if we have to see that what are the risk factors for severe COVID, though it is not, means we see only 10 to 15, or maybe in some studies have shown 20% cases of pediatrics coming up out of the total pool. So what are the risk factors for severe COVID out of that? This is a large systematic review of around 17 studies containing 1,000 plus or more patients. And they found that neonates and prematurity are one of the common risk factors for severe COVID. Also, if obesity is there, diabetes, underlying chronic lung disease, underlying heart disease, underlying neurological disease, and immunocompromised status. So all these factors contribute significantly, that almost up to 1.5 to 2.5 times risk of developing severe COVID is there. What was interesting in this data is that the presence of asthma, which is very much common in for severity in adults, was not associated with severe COVID in children. So if you have to see chronic lung disease, diabetes, obesity, and heart disease, along with prematurity, are some of the common symptoms. If they are there, we have to be very careful that they might go into severe COVID. So I'll be speaking on how have we classified the severity. This is the document published by the Ministry of Health and Family Welfare, which is the latest updated in the January 2022. So they have classified COVID into mild, moderate, and severe. If you have to go into mild, any child with symptoms, URI-like symptoms like sore throat, rhinorrhea, cough, without any breathing difficulty, with normal oxygenation level. So they are classified as mild COVID. So these mild symptoms can be anything: body ache, malaise, sore throat, diarrhea, anorexia, loss of smell and taste, rhinorrhea. Means they are very non-specific symptoms, but they are important symptoms to classify as mild COVID in them. Then we come to the moderate COVID. Along with the symptoms which are present in mild, if we have rapid breathing as appropriate for the age-wise, the child is having tachypnea and the saturation starts dropping, that is comes down between 90 to 93% on room air, they are classified as moderate COVID. And if they develop hypoxemia and signs of severe pneumonia or ARDS or other organ dysfunction or multi-organ dysfunctions, then we classify them as severe COVID and they need hospital or ICU care at that stage. So this is a broad outline if we divide into mild, moderate, and severe. Basically on the basic symptoms, normal URI-like symptoms, along with if they develop tachypnea, they go into moderate stage, and they develop severe respiratory distress along with hypoxemia, grunt, lethargy, or seizures, they are classified as severe COVID. So where do we manage these cases? Mild cases, we all know, are to be managed at home. Usually now we don't admit those cases and we provide them teleconsultation or a COVID care center if the home facilities are not available or you have some difficulty in managing them at home. All moderate and severe cases need to be admitted. Moderate can be admitted in COVID-19 hospital or a district hospital, but severe cases required ICU or HDU care in a COVID-19 appropriate hospital. What do we do in mild cases? We just give basic advice, no specific investigation or medication, just supportive care. We provide paracetamol for fever, good hydration and feeding. You can advise gargles or honey if the child is big enough to do that. And danger signs need to be explained that if these symptoms of moderately or severely COVID symptoms develop, whom to talk and where do they need to report to. Moderate cases, they need to be admitted, but again, the treatment remains the same. We just need better monitoring in those cases, give good hydration, paracetamol for fever. You can add an antibiotic if you're thinking bacterial infection is there. Put them on oxygen if saturation is less than 94. And awake prone is another thing if you can try in those cases that put them in a prone position to have a better oxygenation. And you can add steroids only if you're thinking that the disease is rapidly progressing. Otherwise, that enough is sufficient. Here you can do a couple of investigations like the complete blood count, blood glucose, and chest X-ray, but there is no role of other investigations or treatment in these cases. In severe cases, we escalate our investigation and our therapy both. So you need a better panel of investigation, which include all the main organs like the liver function, kidney function, coagulation marker, chest X-ray need to be done. But what is important is that again, in these cases, there is no role of CT chest, which has been very much misused or rampantly used in, especially in second wave. Start on steroids, but no role of remdesivir. Antimicrobial only if you are suspecting a coexisting bacterial infection or it cannot be ruled out. Provide restrictive fluid therapy, and again, no role of anticoagulation in that. What steroids and how long to give? We usually give for 3 to 5 days. And dexamethasone is the drug of choice, or methylprednisolone, but methylprednisolone is costly. So dexa is a very good drug at 0.15 mg per kg. We give maximum of 6 mg once a day. And give it for 5 to 7 days, and then we can taper it over 14 days. And when do we discharge these cases? We can discharge them after 10 days of symptom onset and the disease has improved, the symptoms have improved, oxygenation is better and he's off oxygen, his saturations are normal, and you are pretty sure that you can monitor them at home and the child or the parents are good enough to self-monitor the child for at least a week at home. And we don't do a RT-PCR at discharge. If we don't need a negative RT-PCR at discharge, we just do a clinical monitoring. If the child is stable enough, we can send him home. So that was the COVID management. So coming to the MISC management, that's a definition for MISC. We always use the WHO definition for that, which include a pediatric old child, mainly coming with fever of 3 or more than 3 days, has any of these two features, like rash, or purulent, non-purulent conjunctivitis or mucocutaneous inflammation, along with hypotension or shock, features of myocardial dysfunction or valvulitis or coronary abnormalities, evidence of coagulopathy or acute GI problems. So any two of these, along with elevated inflammatory markers, which are ESR, CRP, or ProCal, and we rule out other causes of inflammation like the bacterial or viral sepsis, and evidence of COVID-19 either in the form of positive RT-PCR or an antigen test or a serology positive, or in fact, if all these are not available, even a contact with positive COVID patient is good enough to be classified as one of these criteria. So MISC can present in 3 forms. It can present as a case of classical KD, which is less common, which is like Kawasaki disease. These two, like presenting in shock and left ventricular dysfunction or multi-organ dysfunction is the commonest. Or they can just present with high-grade fever with some raised inflammatory markers, but with no other organ involvement. So this also has been commonly seen in our practice. And you have to rule out other infections like all those malaria, dengue. Dengue is very commonly misdiagnosed with the MISC. Scrub typhus is another, enteric is another. You have to rule out toxic shock and bacterial sepsis. In KD phenotype, basically the symptoms could be the same, like fever, conjunctival redness, oropharyngeal findings can be there, rash can be there. You can erythema of the hands and feet, and you can also have lymphadenopathy. So it can become difficult to distinguish between two. But how do you approach this? All children who had a fever for more than 38 degrees, and there is a positive contact with COVID and feature suggestive of MISC, which we have discussed. If they are there, then you see whether any organ involvement or shock is there or not. If it is there, then you do a complete workup, which we will discuss what is tier 1 and tier 2 workup. If they are only fever and mild inflammation, you do only tier 1 workup. And if no other cause is found, you look for alternative diagnosis. And if the child is evolving into MISC, then you do again tier 2 and tier 1 workup and see whether the child fulfill the criteria for MISC or not. So tier 1 basically include, it can be done at a district or a community health center. It include basically the complete blood count with ESR, liver function test and kidney function test with some electrolytes and blood glucose. C-reactive protein is important. Do a COVID RT-PCR, and if negative, you can also test for COVID IgG. Do for other co-infections or other alternative diagnosis, this workup has to be done, and blood cultures. Also, if you think there is another investigations are required based on your clinical approach, you are free to do that. So when do we say this is a positive screen? When your CRP is more than 50 or ESR is more than 40, this is the baseline, and at least one of the following, which include your lymphopenia. This is very commonly seen in MISC, less than 1,000. Thrombocytopenia. Again, this can be a differential thrombocytopenia with the Kawasaki, because in Kawasaki you see thrombocytosis, but not that you don't see thrombocytopenia in atypical KD, but commonly it is the thrombocytosis. Hyponatremia is another. Then you have a neutrophil count which is more than 7,700 and hypoalbuminemia. If any one of these, along with high CRP and high ESR, you go for the tier 2 investigation, which includes some cardiac markers, which is pro-BNP, ECG, echo, elevated TROP-T. You do inflammatory markers like procal, ferritin, coagulation markers, triglyceride and cytokine panels, and you do also the SARS-CoV-2 serology in those cases. When do we hospitalize these cases? If they are having high-grade fever, abnormal vital signs, respiratory distress is there, means any organ which is significantly involved and require more monitoring, we need to admit these cases along with abnormal, significantly abnormal lab markers are there. We need to have an admit and monitor. So MISC can be managed in COVID care areas, but pediatric ICU, they need PICU care if they are having shock, which needs fluids or inotropes. They need any kind of respiratory support or other life-threatening complications are there. So any child with a shock and MISC or other organ, you put this child on IVIG and give it over 12 to 16 hours, 2 grams per kg, and maximum dose is 100 grams. And you also add steroids, methylprednisolone at 2 mg per kg. Antibiotics as per your hospital policy. Observe for 48 to 72 hours if the child is improving or not. If it is worsening, you can increase the methylprednisolone to 10 milligram per kg per day. Again, max is 1 gram. And other biologicals are not reserved only after a specialist consultation. We don't use like lectosilazumab or other drugs. In Kawasaki, you give only IVIG and methylprednisolone at a low dose, again 1 to 2 mg. And again, the pattern is the same. The flowchart is the same. In the cases who present only with high-grade fever and increased inflammatory markers, you don't give IVIG in that cases. Even low-dose methylprednisolone is good enough and they improve with that. If not, then you need a specialist consultation or referral to a higher center. We need ICU care for cardiac dysfunction. If coronaries are involved, shock is there, or MODS. In that cases, if shock or coronary dysfunction or cardiac dysfunction is there, then you don't give IVIG within 16 to 18 or 20 hours. You give it slow IVIG in that cases, maybe up to 48 hours. And steroids, if started, has to be tapered over 2 to 3 weeks. and do a proper monitoring. Add aspirin at a low dose, maximum 75 mg, if your platelet count is more than 80,000 provided. And you give this for 4 to 6 weeks. And if aneurysms are there, it might require longer duration for aspirin. Enoxaparin is very limited indications, low molecular weight heparin. So that is indicated only if thrombosis or giant aneurysms are there. So only in these two conditions, or if ejection fraction is less than 30%. Enoxaparin is limited only for 2 or 3 indications are there. Then you follow up them with the repeat ECGs, echo at fixed time intervals, or as and when required in your follow-up clinic. So again, in these cases, I would like to say that Toci or other drugs are to be used, or Anakinra, they are to be used only after expert consultation and not routine. So to summarize, what we can say is that pediatric COVID, though is not as common as adult, but it is also not uncommon. We have seen it commonly and deteriorating, and even seen children who have died with COVID. And severe COVID, where the ICUs have been full during the peak time with severe COVID. And we have used a lot of corticosteroids at that time, especially in children with hypoxia and severe diseases. MISC again, and this usually presents after 4 to 6 weeks of the peak wave of the COVID when it has come up. And then our ICUs have been filled with MISC cases. And IVIG is first-line drug in these cases along with the methylprednisolone steroids. So thank you so much.
Thank you, Dr. Arun, for summarizing these issues very well. There are a couple of questions that people would like to ask, but although, you know, your topic wasn't on vaccines, most of the questions are on vaccines. Even I had a question about the issue of myocarditis with these vaccines in adolescents. But you can note down a few questions and then you can address them all together. I will just read out a few of those. About what was the mortality in PGI, long-term adverse effects of vaccines. Are these vaccines really necessary if, you know, in children mortality, morbidity are low, and long COVID presentations among children? If you can address these 2, 3, 4 questions within the next 2-3 minutes, it will be very good.
Yeah,
Thank you.
Thank you so much, sir. Mortality is not very high. Like I said, it is around, we had seen around 2 to 3% of cases who had died, and mainly they were not due to primary COVID, that their deaths were less. So it was mainly in those who had comorbidities associated with them. But we have not seen any vaccine associated problems coming up in our center. Any kind of adverse event related to vaccine in children or myocarditis or anything we have not seen or documented. Long COVID, again, we are collecting the data on that, but we have not seen, means the number of cases are not there. What we are seeing is maybe some kind of weakness, lethargy, or some behavioral changes are there. Nothing more significant than that, what we have seen in those. So, and then I'm also seeing we are discussing MISC after first wave now, less so in Delta and Omicron. Sir, in Delta, when the second wave was there, we had again seen loads of cases of MISC at that stage. That we have sent it for publication. It is under peer review. Yes, after Omicron, we haven't seen many cases of MISC, definitely. But in the first and second wave was more severe for MISC. And the number of cases were more at that stage.
Thank you very much, Dr. Arun. That would be all from our side. Thanks a lot.
Thank you so much, sir.
I would now like to invite Dr. Ashish Kakkad, Associate Professor in Pharmacology, a bright young prospect. He is involved in some very interesting projects, especially a product development center of ICMR. And he's been involved in some very good multicentric clinical trials. He's going to talk about regulatory aspects of vaccines in children. Of course, there aren't many regulatory issues specific to children, but we would like to hear from him. Dr. Ashish, please.
Thank you, sir. I hope I am audible. Yeah.
Yes, but a little, volume, increase in volume wouldn't harm.
Okay. Is it better now, sir?
Yes, it is better. Yes.
Okay. Thank you, sir. I'd like share my screen. I hope the audience can see my screen.
Screen is
Yes.
visible. Doctor, she just set your like camera. Screen just your face is not visible fully.
I just
Yeah, this is better. Thanks.
Okay. Thank you. Good evening, everyone. So at the outside, I'd like to thank Professor Madhu Gupta and Department of Community Medicine and School of Public Health for inviting me and for giving me this opportunity to talk about regulatory considerations of COVID-19 vaccines with special focus in children and adolescents. So I'll be briefly talking about the process of traditional vaccine development and how it has compared with what has been done for COVID-19, what have been the enabling systems that have allowed the development of an effective COVID vaccine at super fast speeds, and the specific regulatory considerations, especially for children and adolescents. And finally, I'd like to wrap it up with the current knowledge gaps and what are the future prospects based on the lessons that we have learned during this pandemic. So I'm sure for nearly all of us, 2020 has been pretty much a forgettable year. We have been faced with so many challenges in terms of the scale of devastation of deaths and hospitalizations that we witnessed, limited access to testing facilities, promotion of repurposed drugs, which were eventually found to be inactive, and limitations of access to hospitals and medicines. But despite all these great challenges, there was one field where we have excelled and where we have done exceptionally well, and that is the development of effective COVID vaccines. So if we look at the process of traditional vaccine development, or for that matter, development of any novel medicinal product, it is defined by words such as a complex process, as we can all see here. It is a process which is lengthy. It can take anything from 12 to 15 years or even longer. It is expensive. Latest estimates peg it to be above $2 billion. And it is also risky because out of every 10,000 compounds that enter the drug discovery phase, only one will make it to the market. So what happens in traditional vaccine development is we generally like to start with early exploratory studies involving vaccine design and exploratory preclinical studies, which can take up to several years to complete. This is followed by development of processes for vaccine production and formal preclinical and toxicology studies, which can last up to 4 years, following which an investigational new drug application is submitted. And this is followed by up to 7 years of clinical trials involving phases 1, 2, and 3. Generally, after these phases, a biologic license application is submitted and it is reviewed by the regulatory authorities, which in our case is CDSCO, which can take anything from 1 to 2 years, especially if more data are required by the regulatory authority. And this is followed by the phase of when there is large scale commercial production and distribution of vaccines. So this process can take up to 15 years or sometimes even longer. And it's not only out of caution, but also there is an economic risk assessment at each stage by the developer. So, but what happened during the pandemic was that this entire concept was turned on its head, and we were able to achieve an effective vaccine within a period of about 12 months, that is less than a year. So what facilitated that was we had some prior knowledge about related coronaviruses, that is the SARS and MERS, and we used that knowledge to make an educated guess that probably the spike protein is going to be an effective target for development of vaccines. So that took care of our discovery process. Moving further, we were able to develop processes for manufacture of vaccines based on previously approved vaccines or vaccine candidates. And also we used data from preclinical toxicity studies of existing vaccines, which were used to guide selection of candidates for the preclinical toxicity studies. And from there, we went on to first in human studies. And even during the clinical trials, many of these phase 1, phase 2, and phase 3 trials were in fact carried out in an overlapping manner, and they were adaptive trial designs and seamless trial designs. We'll just discuss them in subsequent slides. And interestingly, even while the phase 3 was going on, we were already manufacturing vaccines on a commercial scale. So this was actually at-risk production because the results of the phase 3 trials were not yet out. But still, it was supported by generous funding from both government as well as non-government organizations. And this ultimately led to a regulatory approval, and also the regulatory processes were speeded up, and which would normally require months was done in a period of weeks to days. And ultimately, we were able to have a vaccine, the first vaccine which was fully tested and was launched in December. So what were the drivers for this speedy development of vaccines? Of course, we had years of previous research. We have been keeping a watch on coronaviruses, particularly the SARS and the MERS coronavirus. Some of the scientists, they actually feel that we were lucky that it was coronavirus, because one is we have been studying coronaviruses, and also the agent itself, coronavirus, is known to mutate relatively slowly as compared to some of the other viruses such as HIV and influenza virus. And of course, the disease process itself was everywhere. We had loads of COVID cases, and we need cases to show that our vaccine works, which was not the case, for example, in case of MERS, where actually the outbreaks were patchy. We had been working on faster ways to manufacture vaccines, such as the nucleic acid vaccines, the RNA vaccines. And in fact, the Moderna vaccine was ready to enter phase 1 within 10 weeks of the time when the SARS coronavirus 2 genome was released by a group of Chinese scientists. Of course, it was supported by generous funding, which de-risked the process of vaccine development. And of course, there was positive regulatory intent in terms that most of the regulatory agencies across the world, they were prompt to take out guidelines to support vaccine development. They were ready to provide advice regarding clinical trial designs and endpoints, and also they speeded up the review process. So all this contributed to rapid development and approval and rollout of effective COVID vaccines. So coming to the regulatory considerations for COVID-19 vaccines, so I'll be primarily focusing on the preclinical and clinical aspects, not to say that the quality aspects are any less important, but in the interest of time, I'll be talking mainly about preclinical and clinical regulatory considerations. So beginning with the non-clinical investigations, so the main aim of non-clinical studies for vaccines is to establish or to evaluate the safety, tolerability of vaccines, its efficacy, as well as immunogenicity in appropriate animal models. So what were the specific COVID-19 aspects in this case was that first, there were mainly 3 kinds of studies which were required. First were the mode of action or the primary pharmacodynamic studies, where generally the immune response, the immunogenicity, and the challenge and protection aspects of the vaccine are studied in preclinical models. So generally before phase 1 clinical trials, immune response evaluation was considered in small animals, whereas in phase 2 and phase 3, it was required to be done in non-human primates and in hamsters. And then another important concept, another important line of inquiry in the preclinical studies was to study the dose response curve so as to select the appropriate vaccine dosing and regimens which can be evaluated in human trials. And finally, an important concept of toxicity assessment. And a particular attention was paid in preclinical testing was to the immunopathological effects. So the immunopathological effects such as the ERD and ADE, which are the enhanced respiratory disease or antibody-dependent enhancement, were particularly monitored in non-human primates and Syrian hamsters. The reason this was done was that we earlier had a signal that there was a possibility of enhanced respiratory disease with the SARS vaccine and with the MERS vaccine. Enhanced respiratory disease is a phenomenon in which the vaccinated individuals, they tend to suffer from a worse disease and a worse clinical outcome whenever they are exposed to a wild type virus following vaccination as compared to unvaccinated individuals. So this was first of all appreciated in 1960s when a formalin inactivated vaccine was launched for respiratory syncytial virus. But there was also a signal while working with the SARS vaccines and the MERS vaccines as well. So this was also studied and had to be ruled out before first in human studies could be carried out. Coming to the regulatory requirements for clinical studies in COVID-19 vaccines. So these are clearly spelled out in some of the the documents which were released by FDA as well as by CDSCO, where all these regulatory agencies, they promoted the conduct of adaptive and seamless clinical trial designs, which could allow for selection between various candidate vaccines and among selection of best dosing regimens to be taken up further in late phase trials. So generally, it was advised that the first in human studies should enroll adult healthy participants who are at low risk of severe COVID-19. So this is generally done to rule out the possibility of enhanced respiratory disease, which could happen in vaccinated individuals. And thereafter, after having sufficient experience in healthy adult participants, it was possible to enroll elderly who were without comorbidities and thus they were not at risk of severe disease. And also it was generally recommended to exclude healthcare workers in early phase studies because they were also at a high risk of COVID-19. Based on the preliminary data from early phase studies, which included assessment of neutralization antibodies as well as total antibody response, as well as Th1 versus Th2 polarization of immune response, a candidate which could be taken up further in late phase studies was selected. So the thing here is it is important to differentiate between Th1 and Th2 type responses, because a Th2 type response indicates that there is a high likelihood that the vaccine might lead to antibody dependent enhancement and thus the enhanced respiratory disease. Therefore, it was favorable to take up a vaccine which produces high titers of neutralizing antibodies and leads to a Th1 biased response. Generally, in late phase studies, they were expected to enroll thousands of patients, and including those who were having comorbidities, that is the high risk patients as well. Coming to the trial designs and the recommended endpoints in early phase, generally it is advised to test the several vaccine candidates and as well as the various dosing regimens so as to pick and select and to down select the most promising candidates and the most effective dosing regimens which are safe as well. And generally in late phase, randomized double-blind placebo-controlled trials are recommended. So generally in early phases of the pandemic, when we do not have a fully authorized vaccine, a placebo-controlled trial might be justified. However, later on, once the vaccine candidates they gain regulatory approval, it may not be ethically acceptable to do placebo-controlled trials. Whatever the case may be, the protocols, they should have pre-specified criteria based on which various study arms, they may be added or removed. And also based on pre-specified criteria only, progression from phase 1 to phase 2 and from phase 2 to phase 3 was possible. And of course, this would require a concurrence from the regulatory authorities. Generally, a follow-up period of 1 to 2 years is recommended. So this is generally advised to look at the duration of protection from infection, the need for booster doses, any long-term serious adverse events, and also any possibility of enhanced respiratory disease once the vaccine immunity wanes out. The most acceptable primary and secondary endpoints were protection against laboratory-confirmed COVID-19, protection against symptomatic disease, and also severe disease and hospitalizations. So one particular concept which was outlined by the various regulatory authorities was the primary efficacy endpoint estimate for a placebo-controlled efficacy trial was to be at least 50%. This means the vaccine should be able to reduce COVID-19 by at least 50% with a lower limit of 95 confidence interval that exceeds 30%. So you'll be excluding vaccines which do not provide at least 30% protection for a lower bound 95 CI. So this was for placebo-controlled studies, whereas for active comparator controlled studies, this 95% lower bound CI was minus 10%. Coming to the specific concepts of pediatric vaccine development. So if we go through the new drug and clinical trial rules 2019, there are several scenarios that are discussed where pediatric medicinal product development is discussed. So one of those scenarios is which applies to COVID-19 as well, where the condition is seen in both pediatric as well as in adult population. So here the testing protocols, they must take into account the pediatric physiological and developmental differences, because children cannot be considered just as miniature adults. They have important physiological and developmental characteristics, which not only make them, which not only affect their susceptibility to disease, but also can affect their ability to mount an effective immune response and also can interfere with immune response to other childhood vaccines. So traditionally, out of abundance of caution as well as lack of commercial interest, the development of medicinal products for children has been delayed. However, the current paradigm is to include them in early phase and late phase clinical trials unless it is justified otherwise. The trials for pediatric vaccines in COVID-19, they have proceeded via the age de-escalation strategy. So this means that the vaccines are first tested in adults, then in older children, and then finally they move on to younger children. So there is sequential evaluation of vaccine in younger age groups. So common example is to first evaluate them in adults, then in 15 to 18 age group, and 12 to 15, 6 to 12, 2 to 6, and then from 6 months to 2 years. Coming to the doses, which need to be studied in pediatric vaccine development, it is prudent to start with the lowest doses and to increase them gradually till an optimal immune response is achieved. And the dosing regimens between the children and the adults can indeed be different. To put this into context, for example, for the Pfizer vaccine, which is administered in children 5 to 11 years of age, is 1/3 of the dose which is administered to children 12 years and older. Similarly, the diagnostic criteria for severe disease and for clinical endpoints, they can be different between children and adults, and they have to be carefully paid attention to. The choice of control group, since the pediatric vaccine development is generally delayed as compared to the adult vaccine development, it may include a licensed vaccine if available, or we may choose a placebo or other vaccine for an unrelated disease. Generally, the endpoints are similar to those in adults, which include protection from serious disease and hospitalization. And long-term follow-up, similar to adults, is generally advised, not only to look into long-term serious adverse events and other adverse effects, as well as to study the period of immunity and the need for booster doses. In fact, there are other ethical issues which are related to pediatric vaccine development, which include the consent from parents, the assent from the children, the community consent, and potential for inducement. So all those have also to be kept in mind while carrying out the pediatric vaccine development. So finally, coming to the knowledge gaps which currently exist and which will perhaps be answered by the ongoing and the future studies is, for example, the influence of maturing immune systems on the efficacy of vaccines. So because a child who is 16-month-old cannot be compared with a child who is 16 years old, because they have different level of maturation of immune systems, which not only affect their disease susceptibility, but also with their ability to mount an immune response. Similarly, what are the long-term sequelae of COVID-19, the disease itself, as well as the vaccines which are received early in childhood? What are the influence of comorbidities, particularly the respiratory disorders, and also metabolic disorders, diabetes, the nutritional status of the child, and psychosocial factors on the response to COVID-19 vaccines? And finally, what is the impact of immunization in the pediatric age group and the generation of effective herd immunity in the community? So perhaps these are some of the questions which are related to vaccine development and deployment which need to be answered. And there are several other knowledge gaps as well, which will be discussed in the panel discussion, which is just coming up. So finally, what are the future prospects based on the lessons that we have learned? So we have been able to adapt novel vaccine technologies, particularly the nucleic acid vaccines, and which has not only improved our understanding of the immune responses, but also some of these technologies are like plug and play systems. For example, we can have a vaccine construct ready for a novel variant of concern within a period of days to weeks instead of months, which was the usual norm earlier. So we have been able to conduct efficient trials with the help of coordinated efforts. Of course, they were supported with generous funding. Will they be available in future? It is only something which can be answered in the time to come. Of course, there were regulatory collaborations. The regulatory agencies, they were supportive of each other as well as of the vaccine developers. And we also have felt the need to develop systems for monitoring other potential threats, because there have been as many as 25 viral families which are capable of infecting humans, and therefore it is prudent to have an understanding of prototypic infections of each of these families. So that will be all. So I'd like to thank everyone for their time. Thank you.
Thank you, Dr. Ashish. Now, there are some questions which have been answered more or less by Dr. Arun. There is one question about whether we have enough safety data to recommend vaccines to 5 and 12-year-olds. I have just one small comment about that risk you talked about when the vaccines were being developed and companies had already started to manufacture. Actually, the risk for companies was very small. In fact, nil risk, because governments had sort of promised that they will be paying them for so many millions and billions of doses. So they did not have much risk. If you can, I think Dr. Madhu is. Do we have time? I think we don't.
Sir, we do
already
not have time. We are exceeded
So,
the time limit, so we can
move to the next session.
Yeah. So panel discussion.
I thank both the speakers.
Okay, thank you, sir.
Thank you so much, sir. Thank you.
Thank you. Yes.
Next year.
Thank you, Dr. Ashish Kakkar, and thank you, Dr. Sameer Malhotra, for chairing the session, and Dr. Ashish Kakkar for highlighting the safety and immunogenicity of COVID-19 vaccines which are available. And now I would like to request Dr. Madhu Gupta to please invite Dr. Sunila Garg for chairing the next session.
May I have a bias? So it's indeed an honor to welcome our chairperson of next session, Dr. Sunila Garg. Everybody knows her, and she does not need introduction, but she's currently chairing the Program Advisory Committee at National Institute of Health and Family Welfare. She's also a chair at Governing Council Academic Committee, co-chair DHR. She was President IAPSM in 2021-22 and also OMAG President. And she's a professor of excellence, and she was ex-sub-dean and head in the Department of Community Medicine, Maulana Azad Medical College, New Delhi. So she has several awards and papers and research projects, and there's so much of things to and lessons.
Thank you, Dr. Madhu. I think we'll go to the next session because we are already running 21 minutes late, to be very precise. So thank you so much, because we should not cut on a very important session. So now the next session is going to talk about safety and immunogenicity of COVID-19 vaccine, which is available for children. And I think the first talk will be, on Covaxin by Dr. Lokesh Tiwari. Is he here, or first we'll have talk by Dr. Abhishek Raut? He is going to talk on Corbevax vaccine. So
I'm Dr. Abhishek.
Dr. Abhishek. So Dr. Abhishek, you are an eminent physician and teacher and researcher, and also a very prominent member of IAPSM. And you have been associated with several committee-based research projects and clinical trials. And you have contributed to RM model, which is a very important initiative of early childhood development that is being scaled across Maharashtra. And you have been lead investigator for the ICMR Advanced Center for Clinical Trial as part of Indian Council Clinical Trial and Education Network that is intent at MGIMS Sevagram. And as a youngster, you have a lot of publications, 40 publications in national and international peer-reviewed journals. So the floor is yours, and in the interest of time, I'll say that please sum up the talk in about 8 minutes time, though I know it's a very, very important topic, and we see a lot of hesitancy now amongst children, and including the, the fact that, the schools didn't open for the sake of vaccination. Our vaccine is there, but then the hesitancy is also there. So without wasting any time, I call upon Dr. Abhishek. So the floor is yours. And I will also request Dr. Naveen to join with me, because I have to join another meeting very soon at 6 o'clock. So thank you so much. And Abhishek, it's pleasure having you here. Thank you so much.
Greetings, ma'am, and greetings, everyone. And warm welcome to all the delegates here. And just give me a moment before I'm able to share my screen. Is the presentation visible?
Yes.
Yes, sir.
Yes.
So whatever I am going to speak, it will be on behalf of our investigators team. This particular trial, the Covaxin vaccine trial, we implemented it as a part of Mission COVID Suraksha. We were selected for that as a site of under Mission COVID Suraksha by the BIRAC DBT. And this is the trial summary at our site, basically. So basically, it was a prospective randomized double-blind placebo-controlled phase 2/phase 3 study to evaluate safety, reactogenicity, tolerability, and immunogenicity of Corbevax vaccine in children and adolescents. There were 19 enrolling sites across the country, of which we were one. that intervention was the Corbevax vaccine, and the comparator was placebo, which was administered in a 3:1 ratio. And there were different primary objectives for the phase 2 and phase 3 study. For the phase 2 study, the sample size was around 134, and the objective was to assess again safety, tolerability, and reactogenicity of 2 doses of intramuscular Corbevax vaccine, but the age group was between 12 to 18 years of age. And for the phase 3, the desired sample size was 490, and again the objective was to assess immunogenicity of 2 intramuscular doses of Corbevax vaccine or placebo, but then the age group was from 5 to 18 years of age. So basically, the overall sample size was 624, of which 134 were in phase 2 and 490 were in the phase 3 study. And the entire study group was from 5 to 18 years of age. In phase 2, basically, it was planned as overall around 8 months of study, wherein there was a screening at baseline, and it had a battery of investigations related to RT-PCR, IgG positivity for COVID and other laboratory biochemical investigations. And based on that, it was decided whether they would be enrolled in the study or not. And then at visit 2, the first dose was administered. There was a specific day 7 safety visit wherein the diary cards were reviewed for any safety related concerns. And all this has been reported to the DSMB. And the second dose was administered 1 month apart, the first dose at day 28. And then there were other follow-up visits. And there is also a booster dose that is planned after 6 months of the second dose. So currently the trial is ongoing, and we have the booster doses that would be coming up in the month of June. All the participants who are enrolled are under active follow-up. So in phase 3, the only difference was the 7-day safety visit was dropped. All other visits remaining same, and the protocol remaining same, that there would be a kind of screening at baseline, and based on the results of screening of those investigations, there would be a decision whether to enroll that particular child in the study or not. So based on this, at our site, we screened 124 children across both the cohorts, the phase 2 and phase 3 cohorts. The total subject screen failure were around 84, 70 of which were because of either COVID IgG or RT-PCR positive. Out of this 70, most of them, almost barring 2 or 3, all of them were COVID IgG positive. There were 7 consent withdrawals. That means their reports were negative, but then before administration of first dose of vaccine, the parents communicated that we do not want to be a part of study. And then there were 6 exclusions because of other systemic conditions. Their blood reports came positive for those tests. And there was 1 equivocal COVID result for which we had to exclude. The number of subjects who were randomized and enrolled were 40, and all 40 are under active follow-up. There are no SAEs that are reported, not just from our side, but the overall entire 19 sites from where these 624 subjects were recruited. So the COMs of none of the sites have been communicated to us, and there have been no SAEs that have been reported from our site. SAE included any fatal or life-threatening or important medical event or condition or hospitalization. So this is the current status of subjects that have been enrolled in phase 2 and phase 3. So all the subjects, like I said, 5 from phase 2 and 35 from the phase 3 are under active follow-up, and they would be due for their 7th visit, that is the booster doses, in the month of June. There were total 7 adverse events that were reported. 3 of them were solicited, which were reported within 7 days of vaccination, and these were swelling at injection site, fever, and arthralgia. We assessed the causality to be certain because these were the solicited events which were expected, and then another 4 events were reported post 7 days of vaccination, and these are the events: the abrasions, upper respiratory tract infection, fever, and tooth pain. So based on whatever follow-up that has been happened till date in this ongoing trial, what we can sum up, one is, which is very important, the background infection rate is very high among children. Like we saw, we screened almost 124 individuals, of which only 40 could be randomized. There were 70 who were either IgG or RT-PCR positive. The indicative data as of now, whatever we know based on the adverse events that we have been able to see, do not indicate any major serious or safety concerns, and probably long-term follow-up will help us gain more insights regarding the safety and immunogenicity of this Corbevax vaccine. So that's it from my end. Thank you for this opportunity.
Thank you, Dr. Abhishek, for very crisply summarizing all your findings. So basically, we can presume that in light of, number of children being infected. So it is very challenging also to carry on with the study. But the major thing what you pointed out is that the vaccine is safe with not many major side effects. That is, I'll say that the side effects are very, very minimal. So it is safe vaccine which can be administered to children. But how to overcome vaccine hesitancy amongst children is also a challenge in front of us. Thank you so much. So I think we can go to the next presentation by Dr. Anand will be speaking now, or?
Dr. Anand, ma'am.
Yeah. So Dr. Anand will be speaking on the COVAX vaccine. And as I can see that he is a recipient of Dr. Anand is a very senior manager of clinical research, pharmacovigilance from Serum Institute of India, Private Limited, Pune, Maharashtra. He is recipient of Dean's Award for Outstanding PhD who displayed academic and research experience, New York Medical College class of 2016. Indeed, a very much honor to have you. He has a research expertise with regard to development of drugs for treatment of pulmonary hypertension, traumatic brain injury, and oxidative stress in cardiovascular disease. He has multiple peer-reviewed publications in international journals and completed his PhD under mentorship of Dr. Melke Volin, a world-renowned expert in the field of oxidative stress, who was part of Dr. Luis Ignaro's team, which won the Nobel Prize for discovery of nitric oxide. Congratulations, and honorary editor-in-chief of pharmacology at statpulse.com. And he is MBBS from Pune, MS Pharmacology from New York Medical College, US, and he has done also his MS in Cancer and Neuropharmacology, Georgetown University, USA, and PhD in Cardiovascular Pharmacology from New York Medical College, USA. So Dr. Anand, the floor is yours, and I'm sure there will be a lot of questions which will be asked to you. So without wasting any time, we go towards your presentation, and time again is 8 minutes for you. Thank you.
Sure. So is my screen visible?
Yes.
Okay. So thank you, ma'am, for the wonderful introduction. So over the next 8 to 10 minutes, I will summarize the safety and efficacy of Covovax. So basically, this vaccine original name is NVX2373. It was originally developed by Novavax, and it is marketed under the brand name Nuvaxovid by Novavax. And there is a tech transfer agreement between Serum Institute and Novavax, and the same vaccine is manufactured by Serum Institute by the name of Covovax. Both the Nuvaxovid and Covovax have been approved for adults by the WHO and by more than 36 countries globally. It is only approved in India for the adolescents age group, that is the 12 to 17. So in India, it is approved in participants age 12 and more. Nuvaxovid is not approved in the population below 18 years of age. So the adolescents approval is currently only in India. So this is just a repeat of what I stated in the previous slide. It's approved across multiple countries and also approved by the WHO and EMA. So I won't go over this. This slide basically summarizes the different types of vaccines available for COVID-19. So if you look at Covovax, it falls under recombinant subunit vaccines, and it contains the whole spike protein against which the immune response is mounted. Coming to the technology, it's a nanoparticle vaccine constructed from the full-length wild-type SARS-CoV-2 virus. It's encoded by the vaccine features, and it contains intentional genetic mutations which allow for an optimized and stabilized structure. It is used with an adjuvant called as matrix M. So this adjuvant is important because it generates a potent, robust, and long-lasting protective immune response. It lowers the doses of the antigen required, thereby fewer doses are needed, which enables increased supply. It improves immune responses and enables vaccine dose sparing. And apart from the COVID-19 vaccine, this matrix M adjuvant is under test in a variety of other vaccines. It's also undergoing testing with a malaria vaccine, for which trials are currently underway in Africa. So these were the key studies conducted in adults with this vaccine: a phase 3 study in Mexico in 30,000 adults, another study in 15,000 adults in the UK, a phase 2B study in South Africa, and then of course there is this phase 1 and 2 study in the US and Australia. So this vaccine has been extensively tested. These are some of the results from the phase 3 studies: almost 90% efficacy across UK and Prevent 19 with the US study. almost 97% efficacy against different strains. Against the variants, the efficacy was 93% against the alpha in the US study and 92.6 against the other variants. And it had 100% severity against the severe disease. So the adult data, it showed that it has got good efficacy against the variants as well as the original strains. It's got robust immune response and it's got a favorable safety and reactogenicity profile. So 4 trials conducted across 4 continents and more than 50,000 adults received the vaccines during clinical trials. If you look at this list is, contains the WHO qualified COVID-19 vaccines. The Serum Institute currently has got 2 vaccines, Covishield and Covovax, which are both approved by the WHO. So we already went into some discussion regarding this. The rationale for vaccinating children against COVID-19, it's to reduce community transmission, protect them from long-term consequences, and avoidance of quarantine, school closures, and other lockdown measures. And pretty sure we'll be having an extensive discussion on this in the subsequent session. So these are the different pediatric vaccines available in India: Covax, Covaxin, Zycovet-D, and Corbevax. Dr. Abhishek Raut spoke extensively about Corbevax. So Covax currently, it's approved in the 12 to 18 age group, and we are in the process of getting approval for the 7 to 12 and then subsequently in the 2 to 6 age group. So coming to the data, so the first was this US trial, which was in 2,200 adults between 12 years to less than 18 years of age. And this trial demonstrated that the vaccine had an efficacy of around 80%. It was well tolerated, no safety concerns against the variants of interest. And at that time, Delta was the predominant variant in the US, so it had an efficacy of 82% against the Delta variant. Coming to the India study, so this was the interim analysis from the 12 to 18 age group. So basically we have the trial underway across multiple age groups in India. So 920 children in the 2 to 17 age group are randomized in a 3:1 ratio to receive either the vaccine or the placebo. You can see the breakup in the table below, and 2 doses are administered 21 days apart on day 1 and day 22. So coming to the immunogenicity data in the 12 to 17 age group, there was a 98.8% seroconversion against anti-IgG and almost another 98% seroconversion against neutralizing antibodies. So this was 14 days after the second dose. With regards to safety, injection site pain, tenderness, induration, myalgia, arthralgia were the commonly reported solicited adverse events. Almost all of them, they were of mild severity and resolved without any sequelae, and no adverse events of special interest or SAEs were reported. Coming to the data in the more than 7 and less than 12 years age group, again over here, if you look at the immunogenicity, the seroconversion was 100%, 14 days after the second dose in the Covovax group. And with regards to neutralizing antibodies, the seroconversion was almost 99%. With regards to safety, again, some of the common side effects were injection site pain, swelling, tenderness, fever, headache, arthralgia, vomiting. Almost all adverse events were of mild severity and they resolved without any sequelae, and no serious adverse events and adverse events of special interest were reported till date. So to summarize, Covax is highly immunogenic and with more than 98% seroconversion for neutralizing antibodies and the anti-S IgG antibodies in children between the 12 to 18 and 7 to 12 age groups. More than 84-fold rise from baseline for both the anti-S IgG and the neutralizing antibodies. Very safe. No SAEs or adverse events of special interest were reported. Very well tolerated in children and adolescents. So even in the about 2 year age group also, it has been well tolerated. And the US study demonstrated that it has got an efficacy of close to 80% in the 12 to 18 age group. So we have a vaccine which is safe, has got good efficacy, and also gives a good immune response. So the take-home message: Covax is a safe, well-tolerated, and effective vaccine, not only for the adult population, but also for the pediatric population. So that completes my talk. Thank you.
Thank you so much. Can we stop the slides there, please?
Sure.
So thank you so much to all the speakers, and I'm covering here for Dr. Sunil Agar. With these two presentations, and Dr. Lokesh is not able to join, but we can broadly say that vaccines which are available in India are being recommended are safe and immunogenic. Definitely, we always like to have more data, effectiveness data, efficacy data, and post-marketing surveillance, but that we don't have that luxury. So the conclusion from these three talks is that we have vaccines which are immunogenic and very safe. Dr. Madhu, can we go to the panel discussion?
Yes, sir. Yes, sir. Now we have enough evidence available, like whatever evidence we have available till now, the talks are done. We can move to the next section. Kiranji, please.
Thank you, sir. And very thank you to the worthy chairperson and all faculty speakers for deliberating on the vaccines available for children and adolescents in India. And it has indeed been a very informative session so far. So now moving on to the next part of our symposium, which is the panel discussion. The panel discussion is going to be on policies related to administration of COVID-19 vaccine among children and adolescents. And this will be moderated by Dr. Naveen Thakkar and also co-moderated by Professor Madhu Gupta. I request Professor Madhu Gupta to introduce Dr. Naveen Thakkar. He is the President-elect International Pediatric Association and Secretary of Child Health Foundation.
Dr. Madhu, I will request we can skip introduction of everyone.
Okay, sir, but it's an honor to have you here. Sir, everybody knows that he's the president-elect of International Pediatric Association, and he has been actively involved in key decision-making at the national as well as international level. So I will be very brief, sir. Thank you so much. Yeah. So Kiranjit, you can skip my introduction. Yeah. So we can,
I think all panelists are very well known. You can just flash the slide, and in the meantime, I will start moderating the session.
So we have among the panelists, Dr. Gagandeep Kang, professor from the Division of Gastrointestinal Sciences, CMC Vellore, and very keen vaccinologist. We have esteemed Professor Dr. Narendra Arora, Executive Director, INCLAN, and also Chairperson, NTAGI. Thank you, sir. And we have Dr. Vipin M. Vashishta, is a Director and Consultant Pediatrician at Mangla Hospital Research Center, Bijnor, UP. Thank you, sir. Dr. Chandrakant Leharia is an epidemiologist and public health specialist from New Delhi. And Ms. Anjali Nair, she is an Executive Vice President, Global Health Strategies, New Delhi. I welcome you all in this panel discussion. Thank you.
Thank you, Dr. Madhu. So let me start as pediatrician and say as a president-elect of International Pediatric Association that we are not only doctors, but also we are advocates for the children. And children have suffered a lot. Initially, when the pandemic started, we said children are the hidden victims of the pandemic. But now we can very well say that children are the worst affected victims of the pandemic, direct or indirect. And when we started, and the initial impression was from data coming from Wuhan, that children are not children don't get infected, children do not transmit coronavirus, and children do not get hospitalized, or and children do not get serious, and children do not die, and children have not suffered. They are just a they have suffered, but it's not a big deal. And second thing was that children, the vaccines are not tested in children, and we cannot use in children, and there is no need for that. But over the times, as the virus evolved, mutated, and we had from Wuhan to Alpha, Alpha to Delta, Delta to Omicron, and the rest of the variant, our panelists will tell. I have stopped keeping track of that, but we learned that with any subsequent variant, the viral load increase in children from Wuhan to Alpha to Delta and Omicron. So we learned from our own study that children do get infected with the seroprevalence study, which you all of know. We know that children have almost infected as the adults. It is also true that all the children do not get very sick, most of them, but talking about that across all age group is not fair. There is a different epidemiology below 5 years, 5 to 10 years, and above 10 years, children do behave as almost as adults. So children do get infected. Children do transmit, not as efficiently as adults, but they do transmit. They have, and with the changing variants, they have high viral load and they do transmit. Children do get serious. Children do get hospitalized, if not to the same extent as adults. And some of the children, they do die. And children are the worst affected victims. And now we have seen presentation that these vaccines, maybe we like more data, and we will have interesting discussion of that. But we have safe and effective vaccine, and India has taken a very good step of growing slowly from high risk age, following a priority framework, and going slowly, studying the how it is used, using very, very safe vaccine, and going slowly. So let us hear from our experts. I invite Dr. Gagandeep Kang. What do you think about need for children, considering different signals coming from different countries? Even from our countries, it is not that we don't have data, but definitely we will never have such type of data which we get from other countries. So what is need for children? And also, is that a uniform need across all age spectrum, or we have to treat the children below 5 to 10, and about 10 separately? Madam, over to you. The audience is waiting to hear from you.
Dr. Thakkar, thank you so much. And thanks for also all the presentations that were done previously. I really liked Dr. Arun Bansal's very sensible presentation on what the experience of SARS-CoV-2 has been in PGI. He was able to show very clearly and mentioned in his remarks that the bulk of severe disease and mortality was in children with comorbidities. In general, for children who are healthy, what do we need to worry about? We need to worry about the very, very, very small risk of severe disease. We need to worry about the risk of NISC, which is unknown in India. We need to worry potentially about long COVID. Now, he told us that he hasn't really seen a lot of long COVID. He described to us that he has seen many cases of NISC, particularly after the Alpha and Delta waves, not so much after Omicron, and also mentioned that in the severe disease cases that they saw, they had high rates of admission without denominators, but that the bulk of mortality was in children who had comorbidities. So the picture is very clear, as you said. The risk of disease is much lower, of severe disease is much lower in healthy children than in any other age group. So now what should we do about vaccines? Well, we have sero-survey data. We know that last year in June, 60% of children across the country were infected in places where there was much better control of disease, like Kerala. It was about 40%, much less than the rest of the country. This year, after Omicron, the sero-surveys that have been done show that 80% of children have already seroconverted. So high rates of infection, and we really haven't seen children flooding into, healthy children flooding into hospitals. So what should we do for vaccination? We need to find the children who have comorbidities and make sure that they are immunized. That is an urgent priority, and we must ensure that there is a high rate of vaccination in children with comorbidities. After that, for healthy children, I think it is a question of, is this a vaccine that parents should give, or is this a vaccine that the government should give? And for the government to give a vaccine, what we really need is an understanding of what the impact of that vaccine will be. And these data are not available. Now, Dr. Thakkar, you said we will never have that data. I am not such a pessimist. I think in India, given the strong public health science that we have, that we are perfectly capable of getting that data if we decide that we want it. There is no question. It doesn't need to be every nook and corner of the country, but we can get the data. So in terms of which vaccines should we use, I think a lot of vaccines have been evaluated for safety and immunogenicity in the country, and they are already being used. Nothing wrong with any of those vaccines. It's just that as a scientist, I really wish that we had head-to-head comparisons of the different vaccines that are available around the world. And we understood what it means to get your immunity from each of those vaccines, every platform, in children, both those who have been previously infected as well as those who have not been previously infected. I also think looking at scheduling of doses is really important. I will call out to the audience to say there are some countries that have not made a decision to vaccinate children. There are other countries that have decided to vaccinate some age groups, but not others. Some countries that have decided that they need to give 1 dose, some countries that have decided to give 2 doses, and some countries that have said that children of all ages, 5 and above, should get boosters as well. Now, each of the countries that is making these decisions is making them based on the data that is available to them. They are borrowing from others, but also using their own data. And I hope that in India, that we will do the same. Thank you.
So thank you so much, madam, for pointing out. So I did not mean that we cannot get data. What I mean that a data which may be acceptable to scientists like you may not be available so early, but we do have data, and I think we will learn from Dr. Arora. Second thing, as you said, that high priority is definitely, first priority is to get all children with comorbid vaccinated. That's true. But we have seen from India and from other that other children also, some of them, they get sick, they get serious, and some of them die. And if we compare, there are good comparison available, which we have seen as pediatrician, that from other childhood diseases for which we are giving routinely vaccination, the burden,
So,
burden as per of the COVID. Yeah, can I complete? Can I complete?
No, I just want to make one point here, which is I have no problem with a parent or a pediatrician recommending a vaccine for an individual child. But when you're talking about a whole country's resources, I will ask you the question, do you know that an HPV vaccine will not in the long term have a better payoff than vaccinating children with COVID-19 vaccines? I think in public health terms,
madam,
I'm
trying to answer that. I am trying to answer that as a pediatrician, because so first thing is, for every child, for family, every child is precious. And as you recommend, as you said, the families have a choice in availability of these good safety and immunogenic vaccine to give their child the vaccine. The second thing is public health. With so much uncertainty and with so much focus on COVID as of now, definitely HPV is coming next year. 24, India will be launching HPV, but all children, they do deserve a chance to get vaccine. And if government has resources, what problem we do have? I think we will, Dr. Arora is waiting, and Madhu will ask him something related, and we will get back, and we will continue to see that children get their due, what is they deserve for long. Madhu,
So,
over to you.
yeah, thank you, sir. So, my question is to Dr. N.K. Arora. Sir, as an esteemed chair of NTAGI committee involved in taking decision at the policy level, I would like you to share with the participant the process of policy making regarding especially the introduction of vaccines, COVID-19 vaccines for children and adults in the country. So on what rationale does the government of India made policy for introduction of these vaccines for children and adolescents? And why was the specific, what were the specific evidence which was reviewed that helped government of India to take this decision? And why are there different vaccines for different age groups? So what was the evidence that led to these decisions?
Yeah, thank you very much, Madhu and Naveen, for inviting. And I was also hearing the previous two presentations and find them extremely valuable. So I think let us go back a little bit before coming to children. Throughout this last 1.5 years, the process of rollout of vaccines has been based on three things. First is prioritization, and prioritization was based on age and risk of exposure to the virus. So basically on profession. So, and the third very important thing was vaccine availability. So because of restricted vaccine availability, this prioritization was necessary. If there was unlimited amount, everybody could have received it right in the beginning, all simultaneously, but that was an important component. And so starting from there, and so as a priority, as you have seen, almost all the adults have received at least one dose, and over 85% of them have received 2 doses of the vaccines today in the country. Now, coming to the question of vaccinating the children. In fact, we had a series of discussion and review of evidence, global evidence. There was limited Indian evidence, but global evidence was reviewed. And a detailed list of comorbidities in children was prepared, and the government was requested that if pediatric vaccination is to be introduced and a pediatric vaccine is to be given, then this priority list, children with comorbidity between 2 years and 18 years, they need to be given vaccine. I must also say that pediatric morbidities are many times not visible as it is in adults. So anywhere between 10 to 12% of children have various kinds of comorbidities, which increase the risk of severe disease and complications. Now, having said that, then you have seen that the initial introduction of the vaccine was in 15 to 18 years. And these 15 to 18 years almost behave like adults. And when we looked at the data, most of the complications or deaths were concentrated mostly between 12 and 18 years, particularly between 15 and 18 years. And so that was the first group. And then it has now been expanded to 12 to 14 years. The immediate question comes that if vaccine has to be given to children with comorbidities, why a generalized policy for giving vaccine to the children? In actual public health situation, identifying these 10 to 12% or 15% children who have various comorbidities has become really a challenging. And that was the reason that even initial prioritization, when 60-year plus was to be given, it was primarily to be given to those with comorbidities. And you remember that between 45 and 60, it was the comorbidities, but within 2 weeks or 4 weeks, it was made generalized for everybody above the age of 45 years. So from a public health perspective, for larger good, this vaccine rollout from 15 to 18 and 12 to 14 years has been done primarily to see that those children who are at maximum risk also get the vaccine in the process. And therefore, in various social mobilization campaigns also, both for adults as well as for children, comorbidity is an important component, particularly those with chronic disease. These may be cancers, chronic lung, liver, heart disease, congenital heart disease, neurodevelopment disorders. All of them are at higher risk of complications. Recently, there was a question from Supreme Court about disabilities, and it was regarding more about boosters for disabled individuals, adults. Again, the same issue, that unless you give it for wider perspective, those selected group in a public health becomes challenging. Now the question, another very important component over the time we should remember, there are two things. That although the complications are rare, acute complications with COVID are rare. And this is also correct, as Professor Gagandeep has rightly said, that the infection rate, whatever was happening in adults, was also happening in children. The only difference was we were not seeing serious or severe disease or deaths. We reviewed the data last week, and during December, during 2022, the deaths in children below 18 years, and it was uniformly spread out between 5 years to 18 years. In the previous two waves, the death rates relative to overall was 0.97 and 0.7%. That means 1% in the first wave and 0.7% in the second wave. In the third wave, we see that proportionate death in children was 4%. So there has been a proportionate increase, not in absolute numbers, because absolute number of deaths during last 6 months has been much less as compared to the previous one. And the possibilities are that the number of deaths in adults have come down because of widespread infection plus vaccination. Most of our adult population is vaccinated, and that is obviously providing some protection. So children who are still not received, although they have been exposed to natural infection, the deaths have relatively increased in this. So from this perspective, this appears that vaccination in children does provide, it may not be as it may not have as what it should say, the prominent impact as in adults, but children do have an additional impact. Finally, coming to two more points. One is, there was a time that there was shortage of vaccines, and which now no more exist. We have effective vaccines for various age groups, and we have India is one of those countries where we shut down all the schools, and even now, till the children are immunized, parents are hesitant. They want their children to be vaccinated. So that is another dimension, but it is not a science issue, but from a policy perspective, those issues are also considered at policy level. And finally, the issue of boosters has never been talked about, and therefore we would be at the moment, the whole focus is that most of the children between 12 to 18 years should be immunized. Data below 12 years has been reviewed. We are in the process of looking at it at various levels of ANTAGI, and decisions may take some time. I see a lot of questions coming up from a few participants about deaths due to vaccines, the damage vaccines may cause, and many of the other related issues. So I must say the vaccine safety surveillance is trying to look at both adults as well as pediatric age groups. We don't have the best of this AEFI or vaccine safety surveillance, but at least in the first week after the vaccine is given, the safety surveillance is reasonably good, and so far no serious signal has been found with either of the pediatric vaccines. Either Covaxin or Corbevax has been given. Several crore doses have been given so far. And from time to time, Dr. Harsh Mahajan is asking, when are we going to initiate 5 to 12? And there are some other questions also. I would not be able to give any timeline, but we are looking at various data, and I think we'll have to wait for some more time for a policy decision on. There also, the focus will be that children with comorbidities should get the vaccine. Thank you very much. And why are there different vaccines for different age groups? I think this is excellent question, and this is related to vaccine availability. So 15 to 18 years, Covaxin was started because there was no other vaccine at that time for children. 12 to 14 years, Corbevax was included because Covaxin couldn't have matched with the requirements of 12 to 14 years, and therefore this kind of a thing. Although both vaccines can be given between 12 to 18 years also. Below 13 years, we have Covaxin now, Corbevax, and now just now I saw Covax data also. So as we see, vaccine availability is also an issue which is taken into account when these policy decisions are based. Thank you very much.
Thank you so much, sir, for enlightening. I think this is very enlightening, and we have understood what processes are taken place to come to this decision. I just have one question for you, sir. Like, this is not, I mean, COVID pandemic situation, right? I mean, we are not seeing so many positive cases. So, I mean, is it okay that if we wait for the vaccines to show their efficacy and then maybe revisit? I mean, is there a possibility that, or is it like that once we have decided now we cannot go back, and we cannot think that our decisions were somewhere not as per the evidence? I mean, that time the decisions were taken totally as per the evidence, and you said that it was difficult to identify children with comorbidity, so that was a good decision. But now that since it's a lean period, I mean, I do not know, but maybe I don't know whether this is a relevant question, but maybe we can have some data on efficacy.
I will try to answer that. Now, vaccine efficacy or effectiveness, let's talk either of these words. There are 4 types of vaccine efficacy or effectiveness. The first one is vaccine is effective in interrupting the transmission. Most of the vaccines are inadequately effective, less than 50%, whichever vaccine globally you talk about. The second is vaccine efficacy or effectiveness to prevent symptomatic disease. This varies between 50% to 95%. Various vaccines, some vaccines we say good, some not so good, but they have this kind of vaccine effectiveness. And the third vaccine effectiveness is that prevents serious disease. And the fourth one is which prevents disease and death. It is fortunate that irrespective of the vaccines, most of the available vaccines, including those in India, are more than 92 to 95% or even 98% effective in preventing severe disease and death. So therefore, I think the way when we use the word efficacy or effectiveness, it has to be seen in that context. Second, today when the vaccines are available, a comparison of it can be only the comparison between 2 vaccines. but unfortunately in children, we do not have that kind of efficacy data now available. And particularly because our asymptomatic infection rate or children exposed to infection is so high. We heard Serum Institute that they had to screen 200 children to get 40 children which were not infected. So today it becomes very difficult to get that kind of information. So most of the information we are talking about today is not a randomized controlled trial to look at various kinds of efficacy, but it is immunobridging studies. And I think some other time one can discuss in greater detail, but there are ethical issues and actually logistical issues that at this time, these efficacy studies are really challenging. Over.
Thank you, sir. Thank you. Sir, Dr. Naveen.
Thank you, sir. And I will add that even this efficacy and effectiveness for serious disease and death have been even seen with the changing variant. So that's a good thing. With the new variants, the efficacy for symptomatic disease is going down, but fortunately, it is still all the vaccines are effective against even Omicron for serious disease and death. So thank you so much, sir. And now I will want to ask, can we go to the next slide? Yeah, to the, okay. So Vipin, what is your opinion regarding the superiority of a particular vaccine against other for pediatric adolescent age, which might be best possible vaccine for the pediatric adolescent age group in Indian context? You have, writing so much about this. So may I request you to say a few words about this, Vipin?
Yeah. Thank you, Dr. Naveen. Am I audible?
Yes, you are audible, loud and clear.
So before answering your query, I think I must go back to the initial question. First, we realize what is our objective of vaccinating kids. Okay, it depends. I think it is mainly what I understand is to provide protection against severe disease and death and hospitalization. You see, but what policies, particularly public health policies, they depend upon the assessment of the risk. And you cannot assess the risk without having the age stratified data regarding the various aspects, whether the severe disease, hospitalization, death. And we talk of these efficacy number, they are basically relative risk reductions number. A vaccine which is 90% efficacious, it may have relative risk reduction up to 95%. But what is more important in public health is the absolute risk reduction. What is the attack rate, difference between the attack rate in the vaccinated and non-vaccinated? That is more important. Say, take the case of Pfizer vaccine, which is 90% efficacious, but the relative reduction risk is around 90%. But if you take the absolute risk reduction, attack rate between those who are vaccinated and not vaccinated, it is around less than 1%. So we must have data. We cannot run away without having proper data. And second is Dr. Previous speaker said that these vaccines are basically meant to provide protection against the severe disease and death. They are not provide protection against asymptomatic infection, not against this transmission. And even you see this efficacy, effectiveness against the symptomatic disease is also, you talk of Omicron. I was going through one of the studies and they found that this Covaxin is only hardly 46%. Against the Delta. But if you talk of Omicron, I don't think that our vaccines will be anywhere effective more than 20 or 30%. And that is for a point estimate. If you go down the line, say after 6 months, the efficacy may not be at all available. You see the AstraZeneca against Omicron in the UK FHSA trial, it was only 0% effectiveness after 4 months of the second dose. Similarly with Pfizer, it was only 15% after 4 months. So we need to be quite sure about what our objectives are and what is the data. Coming to these vaccines, which one is more superior? I think right now we have in our basket 3 or 4 vaccines. First is Covaxin, which is there. Another is Corbavax. Then we have Covax and Zycov-D. I think government has already introduced 2 vaccines, which is Covaxin and this Corbavax. If you go for their safety study, I think all these vaccines are safe, and you cannot compare the safety profile with the new nucleic acid based vaccines globally. So as far as safety is concerned, apart from ZyCoV-D, which is DNA vaccines, I'm comfortable with all the three. They are equally safe. This ZyCoV-D is a DNA vaccine that is developed on a newer platform. And I think I would like to see much more data and much more time and much more larger population being inoculated to pick early pointer to autoimmunity. You see, this is the important issue, is autoimmunity. Most of these cases of pericarditis, myocarditis, and GB syndrome, VITT, they have something to do with some amount of autoimmunity. So we need more data, and I appreciate the government decision. They have not straight away go with the ZyCoV-D. Maybe there may be some other reason. Coming to the efficacy point, you see the Covaxin is not that immunogenic. As I said earlier, in Delta also, its efficacy was around 46 to 50%. And if you think of Omicron, it may be even in early 10 or 20s. So I'm not very sure as far as the immune efficacy point. This is regarding the symptomatic disease. And this is not true that there is no waning of protection against severe disease and deaths. We have seen that in other Israel, in the UK, even in the USA, a large study in healthcare workers, and they found there is significant waning of protection even against severe disease and death. So we need to be careful about what we are going to achieve by these vaccinations. Coming again to this question, I think apart from these vaccines, Corbavax is highly immunogenic. It is superior as far as immunogenicity point is concerned. We don't have efficacy data, we don't have effectiveness data, but it's definitely score over Covaxin and other vaccine, which is viral vector vaccine. But the issue with Corbavax, it is a RBD-based vaccine. So any mutation occurring during this on this RBD of spike protein of SARS-CoV-2 might affect the effectiveness and the efficacy. So we are left with COVAX. I think this is one vaccine which, in my opinion, it should work wonder, because it is definitely developed on a platform with new technology. For example, they have used a nanoparticle technique, and they have taken a new plant, saponin, which is matrixam, as an adjuvant. If you see, if you study the spike protein of SARS-CoV-2, there are certain areas, certain regions, and you can call them its epitopes, which are conserved through various across all variants. So this vaccine, when it presents to the muscles, to the immune system, it presents in such a way that these epitopes, which are conserved, they are exposed, and the more antibodies are formed against these conserved epitopes. This is the beauty of this product. I think in due course of time, it may work equally well against the existing and the newer variants which may emerge in future also. This is mainly because of these conserved epitopes. So I'll keep, as far as efficacy point, Covax at the top, followed by Corbavax and Covax.
Thank you so much, Vipin. You have highlighted two very good points. There is a, as I said previously, when we talk about efficacy and effectiveness, as Dr. Arora said, what we are looking for. And public health perspective, we are looking for prevention of serious disease and death. And that also applies for the waning of immunity with time. There is a difference, and as Vipin said, efficacy particularly goes down for symptomatic disease, and particularly what we have seen in US and with other vaccines, we don't know about, there is some data from us, but from here, but definitely when we talk about serious disease and death prevention with these vaccine, there may be other factors in play like T-cell immunity, and it may be still work for a long time. So this is good. You have given your choice, but I would say let us leave it to the subject expert committee. Entagi, Dr. Arora is here. All these vaccine will be brought to the program, will be seen from the point of public health perspective, which is prevention of serious disease, death, and hospitalization. And all these vaccines are working well. And whenever there is a need, maybe government may consider booster. So with this, I pass on to Dr. Madhu Gupta for the next panelist.
So I invite, yes, I invite Dr. Chandrakant Leharia. So So what is your opinion on the mandate by the court regarding it is not compulsory for children to be immunized for COVID-19 vaccine for attending offline schools? And what do you think that how do we meet that high risk group in the school so that they are not left out? Thank you.
Thank you, Dr. Gupta. So in my opinion, if a court, a Supreme Court of a country need to intervene to say that it's not compulsory for children to attend vaccine, it's very unsettling. Like this is something which should have come from the program managers and which is always known. Government keeps saying that vaccination, COVID-19 vaccination is voluntary. And even then court had to come up because various schools and various authorities are doing, and none of the health officials intervene and clarify that. That reflects a broader challenge in vaccination program. That's one. Second part is that we heard from Dr. Kang, who highlighted that vaccination, especially vaccination of children, is bigger priority for high-risk children. Dr. Arora said exactly the same thing, but Dr. Arora added that it was made for all children in 12 to 17 years because of operational reason, because it's difficult to identify. So essentially everyone, technical expert and government is saying that vaccination should be done for a voluntary basis for a high risk group and possibly for all children, but there is no point of compulsory thing. But this has happened, so we need to understand what is the root cause of this thing. And to me, it has origin in during the pandemic. We have been using many of the terms very loosely, like vaccine mandates and mandatory vaccinations are two compulsory, completely different things. Like what is vaccine mandate? That a few group of people, vaccine mandate means like if people are not vaccinated, their access to public places can be restricted. But vaccine mandate does not mean that vaccination is mandatory for people, which essentially mean that people need to get themselves vaccinated, otherwise they would have to face some penal cause. So making that kind of thing, that children requiring a vaccination certificate to attending school, is I think something which should not have been done, which should not have happened. And why this kind of confusion arose, like we need to understand that while some reasonable restrictions on the behavior of the people, like access to public places, other is possible in the times of pandemic because it poses a public threat. But it's also individual choice at individual level. Like if this is, we know that this vaccine does not reduce, none of these vaccines reduce the transmission, so that there is a limited benefit of making them mandatory, the cause which we are saying. And the individual benefits are there, and which should allow people the choice. And for especially for children, the risk is high for children, so that's the approach should be. I think deriving from this, we need to derive some lessons, and the public discourse should be guided by the science and not something which is like a forceful. I stop here.
Yeah, thank you, Dr. Chandrakant, for highlighting that it is definitely as per the decision by the beneficiaries who are about to take it. So thank you so much. Over to you, Dr.
Yeah, can we go to the next slide? And our final panelist, Anjali Nair, who has worked for a long time in this space and have a very good experience. So Anjali, considering the current evidence around COVID-19 vaccine among children and adolescents, how we, you heard from different perspective that, it's not mandatory, but still schools are, some schools are making it mandatory. We heard that, the high risk children should be prioritized. And if the parents want to take the vaccine for their children, they can definitely take the vaccines are safe, and it's difficult to screen all the children and all those things. So what do you think, how we can go about that, using like parent teacher association, teachers representative, or how do we go about so people can have an informed choice, and those who really need vaccine, they get it, they are not afraid of because sometimes it gives wrong message that the Supreme Court has said you don't need, it's not compulsory. But compulsory or mandatory, if it does not mean that if you cannot take vaccine, or these are not say safe or effective. So Anjali, over to you. Are you there? Madhu, Anjali is there?
She was there only, yes.
Can you check?
Ah,
Or
she's
anybody
here only.
wants
Yeah,
to?
Now I've been able to unmute myself. Thank you, Dr. Thakkar. I'm sorry, I had a bit of a problem with the internet, so I'm dialing in from my phone, and maybe that's why there is this confusion. Dr. Thakkar, one of the things that, I've been listening to the discussion, and thank you so much, Dr. Madhu Gupta, for including me. And, it's really wonderful to hear all these experts. And I'm going to just turn the table a bit, because I'm going to put my layperson hat on and kind of pretend that I really don't know anything or don't really understand the science. So what I want to say is that deciding about vaccinating your child, or even anyone recommending to a parent to get their child vaccinated, whichever vaccine is there may be, or even to get vaccinated at all, is a very big decision. And reasons for, let's say, any vaccine hesitancy amongst parents is completely different to that in adults, because you're really thinking about giving something to to the most precious thing in your life. And I think it's also very important for us not to dismiss any concerns that anyone has, whether it's a parent or any other stakeholder or even an expert, where we question. And all these concerns have to be addressed very, very clearly. So if we all want to combat COVID-19, it's important that we all do our part, that everyone is protected and safe. But it also requires us to make the information more accessible than misinformation. What is also happening is that there are several. So, first of all, COVID vaccines were available just last year, or about a year or 18 months ago. And we've got to keep that in mind as we start developing any kind of strategies or any kind of messages that we need to provide. And all of them have to be clear, they have to be transparent, they have to address concerns, and they have to make sure that people are confident to give the vaccine to their child. So, Dr. Thakkar, I mean, one of the things that happened in all the confusion about asking me to join is I missed the last part of your question. So if you could repeat it, I'll address it very specifically. But for me,
so
really,
what I am saying, as you have, you already said, that because of say these concerns, and we need to address these concerns. So you can hear from everyone. Nobody is saying here that vaccines are not safe. Definitely, we would like to see more data. Nobody is saying here that they may not be effective, but for symptomatic disease, the efficacy may vary. With all this, and you heard Dr. Arora, what are the public health concerns? So how we still we are not able to communicate message, although we are all on same platform. We are not able to communicate this to the parents. We are not able to communicate this to the families, that and nobody is saying, nobody is advocating here a mandatory vaccination.
Right.
But so how do we deal with this? These issues. You are the best person to tell this group and make a recommendation.
Absolutely. I think one thing we have to understand, that the information that we are giving, absolutely the vaccines are safe. It isn't mandatory. But as a parent, what are the two questions that a parent will ask? First of all, are the vaccines safe? Yes, they are safe. Which is the vaccine that's most suitable for my child? And will there be side effects? I think, Dr. Thakkar, both you and Dr. Arora know that it's not just the vaccines
that COVID vaccines, but even for any other vaccines, these two are the basic questions. And unfortunately, we are also, what COVID has done is there's been an explosion of misinformation. And for some reason, our positive information has not been able to cover the misinformation. And maybe we shouldn't even go there. I think what we have to do is target the 2 or 3 persons that a parent will go to. One is, of course, the doctor, or the local doctor, or the pediatrician, or the teacher. And for all this, there are various ways that you can get the information to them. School teachers and schools are the best way to also get the information. And we did that, although it's not the same thing, but we did that for iron folic supplementation and deworming, where we formed groups and we formed master trainers of teachers who were given complete information, and they in turn trained the other teachers in the school. So my big thing here is that even though the media has had a significant interest in COVID-19 vaccination, there has been different voices that come up, and not everything is explained very clearly on the 2 questions. Are the vaccines safe? Yes, of course, everyone says they're safe, but what vaccine will I give to children? Also, a lot of parents, with this social media, a lot of parents know what's happening in other countries. A lot of parents know that there are other vaccines probably have better results. And there are questions, why can't those vaccines be available? So I think both Dr. N.K. Arora has been on various media channels, and I've heard him say again and again, but I think we need to give out the evidence in simple, easy to understand forms through the local physicians, through the pediatricians, and through the teachers.
Thank you so much. Thank you, Anjali. Madhu, do we want to wind up? We are already late.
Yes, sir. Please summarize.
So I think message is very clear. Nobody, we are very clear that there is no mandatory vaccination. It's definitely a choice. Vaccines are available, and what vaccines are available in India, they are safe. Why different vaccines are used, Dr. Arora has already told. When you make a policy, when you work for a whole country, you have to see the availability and all these vaccines which are available. And as Vipin also said, there is, if more data is available on Zycovid, definitely, as of now, that's why government has not rolled out that. So that's important. And vaccines are working as far as the different variants are concerned, at least for serious disease, death, and hospitalization. And we need to have a very transparent and honest communication and targeted communication. Dr. Arora has already written in the chat. Anjali has told us whom we have to reach out, what talking points we should have. And I think many of policymaker and office bearer of different organizations, I can see from IMA, IAP and others, and Dr. Arora and everyone will take this to the policymakers. That is still a lot of work is required in the field of communication. I always say that we did everything from mock drill to even, but we failed to read the minds of the people. We failed to read the minds of people when we started for health worker. They said, why you are giving us vaccine? Why the prime minister, politicians are not taking? And then there is if you have a vaccine, real vaccine hesitancy, it is really in health workers and the health professionals. If they are convinced, they can very well convince other. So I think Anjali, I will add to that. We have to work with the health professionals and health workers to convey right, because this efficacy, effectiveness, what different efficacy we have failed. All the companies, in beginning, they came out not in the peer-reviewed journal, but in the press conference with efficacy data, which was for the symptomatic disease. we realized maybe after 6 months that we need to talk about the efficacy and effectiveness for the serious disease and death and hospitalization, and then the things improve. So I think we will stop here, and most of the questions are answered in the chat box, but a lot of work to do. And thank you PGI team for this wonderful session, and which was I hope we can see everyone has liked it. Over to you, Madhu, for final comments.
Thank you. Yeah, thank you so much, sir. I think it was indeed a wonderful discussion, panel discussion, and the sessions which were held today as part of National Symposium. And I think this was the need of the hour, and I think the aim of the symposium has been met because of the august presence of the technical expert and the resource faculty. So from the bottom of my heart, I'm very thankful to the panelists and the moderator, Dr. Naveen Thakur, Dr. Narinder Arora, Dr. Gagandeep Kang, Ms. Anjali Nair, Dr. Chandrakant Leheria, Dr. Vipin Vashishta. Thank you for making it very, very useful, and it was actually enlightening for me as well. I'm very thankful to the resource faculty, Dr. Arun Bansal, Dr. Ashish Kakkar, Dr. Abhishek Raut, and Dr. Anand Lakkar from Serum Institute, and our august chairperson, Dr. Sameer Malhotra and Dr. Sneela Garg. I'm very thankful to my team, Dr. Kiranjit Kaur, Dr. Anchal, and Dr. Adarsh, for making this happen within a very short span of time. So if you have further questions, the audiences, I'm very thankful to you because you have been the key listener till the end. So, and many of the participants have joined with us on the YouTube link as well. Video of this will be available, and it will be shared with you on a social media. So with this, I would like to thank everyone for being a very good listener and very good technical experts. Thank you so much. Yeah.
Thank you so much, ma'am, and thank you so much to all the panelists and all the faculty members for enlightening us with this very important topic and very hot topic that is going on these days, and we have learned a lot from these sessions. So now with this, we come to the end of this symposium, and a link for the certificates has been shared with you in the chat box and also on YouTube chat box. Just please make sure that you put in your correct email ID and your correct name, as the certificates will be shared automatically, and the link will be valid for next 2 hours. So that is all for today, and with this I would like to close the session, and hope you have a very good weekend. Thank you so much, everybody. Thank you, sir.
Certificate link will be available, no? Or sometime.
Yes, ma'am. So certificate link is available for next 2 hours, and I will keep this window on for another 15 to 20 minutes so that everybody is able to access the link, and they can submit their email IDs and name for the automation. Thank you.